Hi, I'm Samira Sankhe, intern from Vedic Dental College. We are discussing here expansion in orthodontics part 2. Here I'll be continuing with rapid maxillary expansion, which is also said to be RME, also known as rapid palatal expansion or split palate. It is a skeletal type of expansion that involves separation of mid-palatal suture and movement of maxillary shelves away from each other. As we all know, Emerson Angel is father of rapid maxillary expansion. In 1860, he used expansion-like device in which jack screw type of device was used between maxillary premolars in 14-year-old girl child, which also achieved increase in arch width by 1/4 inch in 14 days. We can see that appliance photograph in the slide above. Here we will continuing with applied anatomy. Uh, in this, the maxilla together with palatine bone forms the hard palate floor and greater part of lateral walls of nasal cavity. Most of the suture attachments of maxilla to adjoining bones are at its posterior, superior aspects, leaving anterior, inferior aspects free, which makes it vulnerable for lateral displacements. So, the suture present between two palatine shelves or two maxillary shelves, which is also called as intermaxillary suture or interpalatine suture, which is collectively called as mid-palatal suture. Three stages of mid-palatal suture development. First stage, infancy stage, in which there is Y-shaped suture present, where the vomer binds with palatine processes, and it gives a Y-shaped configuration if it is viewed in coronal section. Stage 2, the juvenile stage. Upper portion of Y flattens out and vertical portion develops curve, effectively increasing suture's length. It also gives higher assuming T-shape configuration. Stage 3. By adolescence, suture may become densely interdigited as giving appearance of jigsaw puzzle associated with full maturity. Now we will see effects of RME on maxilla, maxillary teeth, mandible, nasal cavity. First, effect on maxilla. On maxilla, there will be opening of mid-palatal suture and there will be downward and forward movement of maxilla. First of all, maxillary posterior teeth will be used as handle to apply transverse reciprocal force, so which will open the mid-palatal suture, and it will also compress periodontal ligaments, bend the alveolar process buccally, which will slowly open the suture, and suture will be opened in fan-shaped or triangular split with maximum opening at incisor region and gradually diminishing towards the posterior part of palate. This can be appreciated in post RME occlusal radiographs. Similarly, fan-shaped or non-parallel opening is also seen in supero-inferior direction. The maximum opening is towards oral cavity with progressively less opening towards nasal aspect. According to Krebs, the two halves of maxilla rotate in sagittal and coronal planes. Second is effect on maxillary teeth. There will be midline spacing between two maxillary central incisors, and maxillary posteriors will be used as handles, so which will lead to buccal tipping and extrusion of molars. As we can see in this picture below, the axial inclination of anchor molars normal, and when they are used as handle during RME, so they are buccally tipped. Now effect on mandible. As there is evident effect on mandible, downward backward rotation of mandible, increase in facial height, there is reduction in overbite and increase in mandibular plane angle. Next is effect on nasal cavity, which is also evident because reduced resistance to the nasal airflow about 45 to 60%, which improves nasal breathing and also increases intranasal space. Maximum in inferior region of nasal cavity and gradually decreases towards superior aspect. Indications for RME: posterior crossbite, class 2 malocclusion, cleft palate patients, face mask therapy. Medical indications: nasal stenosis, septal deformities, recurrent ear and nasal infections, allergic rhinitis. Contraindications: single tooth crossbites, uncooperative patients. After ossification of mid-palatal suture, it is accompanied by adjunctive surgical procedures. Skeletal asymmetry of maxilla and mandible. and with severe anteroposterior skeletal discrepancies. Diagnostic aids. The routine diagnostic aids are case history, clinical examination, study models, maxillary occlusal view radiograph to see mid-palatal suture, PA cephalogram to estimate amount of expansion that has taken place. RME appliances. Numerous appliances have been used for rapid maxillary expansion. Broadly, they can be classified as removable and fixed. In fixed, there is tooth bone and tooth and tissue bone. In tooth bone, there are examples of Isaacson type, Hyrax type, and tooth and tissue bone, there is Derishwiller type and Has type. Where in tooth bone, the support is taken directly from the tooth structure, whereas in tooth and tissue bone, the support is taken from tooth and tissue, which by using acrylic plates. Isaacson type, this is tooth borne appliance. This is appliance having a special spring loaded screw called mine expander, which was given by University of Minnesota Dental School. It consists of coil spring having a nut that can compress the spring. It is soldered directly to the bands. No acrylic is used, easy to fabricate. An expander is activated by closing the nut so that spring gets compressed, as we can see in the picture below. Next, Has type. This is tooth and tissue bone appliance. In this appliance, the first premolar and molar on either side are banded. A thick stainless steel wire is used of about 1.2 mm diameter, soldered on buccal and lingual aspects connecting premolar and molar bands. Lingual wire is kept longer so as to extend past the bands both anteriorly posteriorly. Free ends are turned back and embedded in acrylic. Expansion screw is also incorporated, as we can see in picture below. Derishwiller type, this is also tooth and tissue bone appliance. In this, the first premolar and first molar are banded. The wire tags are soldered onto the palatal aspect of bands, and wire tags are inserted into split palatal acrylic plate, incorporated a screw at its center. This is Hyrax type. This type of appliance makes use of special type of screw called Hyrax, Hygiene Rapid Expander. The screws have heavy gauge wire extensions that are adapted to follow the palatal contour and are soldered to bands on premolars and molars. This is tooth-borne appliance mostly used. As of now, we can see all four appliances in one picture. Isaacson, Has, Derishwiller, Hyrax. You would be thinking what is the difference rather than tooth-borne and tissue-borne thing. There is a difference, as we can see in Has and Derishwiller. They both are tooth and tissue-borne. But in Has appliance, the wire is used. So the support is distributed to wire and then to tooth structure. Whereas in Derishwiller, the support is taken from tooth as well as tissue, but the wire is not used in this appliance. It is direct. The acrylic plate is connected to tooth structures without using wires, so the stress force is not equally distributed. Bonded RME. Most of the RME appliances described earlier are banded. They incorporated bands on premolars and molars. Alternative design for this appliance would be adding a splint covering variable number of teeth on either side, and which is attached to jack screw. Raymond Ho in 1982 developed this appliance. It clears the palate from acrylic. No banding needed. Can also be used on malposed teeth where parallel path of insertion is not possible. Less prone as bands don't have to be placed in impression. Easy to make on deciduous teeth and mixed dentition period. Here we can use cast cap splints, acrylic splints. It also limits the extrusion of molars and improve overbite control. Mostly used is bonded hyrax. Here there is picture of bonded hyrax with hooks for face mask in class 3 malocclusion for carrying out protraction of maxilla. Now we will see activation schedule of appliances. Schedule given by TIMS. Up to 15 years of age, the turn of 180 degree is given as 90 degree in morning, 90 degree in evening. Over 15 years patient, 45 degree activation 4 times a day is given. According to Zimring and Isaacson in 1965, young growing patients should be given 2 turns each day for first 4 to 5 days and later 1 turn each day for remainder of RME treatment. Non-growing adult patients, 2 turns each day for first 2 days and 1 turn each day for next 5 to 7 days and 1 turn every alternate day till desired expansion is achieved. Now we will see the description of typical expansion screw. The screw consists of two halves. One half is threaded in a inner side and another half is double-ended screw. The pattern of threading is on either side is of opposite direction. Each half of body gives rigid connectors. There is central bossing present with 4 holes. The activation key is usually a rigid metal rod with plastic handle. It is inserted into the hole present, which is central bossing, and turning of screw by 90 degree, which is equal to 1/4 of turn. As I can give example of a screw with 1 expansion. If I gave a 90 degree turn to 1 screw, how much it will be? How much expansion will be achieved? 0.25 If a 1 screw is given 90 degree turn, it will give 0.25 expansion. So if the screw is given 4 turns, which is 360, so it means it will give whole 1 expansion. Now we will discuss hazards of RME. Hazards of RME: poor oral hygiene, length of fixation, dislodgement and breakage of tissue, damage, infection, pain or discomfort, dizziness, pressure at bridge of nose, etc. Cleft palate cases: excessive anterior collapse coupled to little or no posterior collapse. More fan-wise expansion needed to restrict posterior expansion. Screws of longer threads up to 18 expansion are used. More difficult to retain during clinical crowns are not developed properly. Unilateral expansion, both with the help of cap splints or bands, can be used. Formation of fistula is a very common complication. Expansion of mandibular arch. Stable expansion is difficult to attain in lower arch. Present studies say that expanding the upper arch allows for spontaneous expansion of lower arch. We can see in this picture. There are different other methods of expansion. First is mini implant assisted rapid palatal expansion, which is MARPE. In this, mini implants or temporary anchorage device, which is TADs, are also used in place of tooth-borne appliances. And this method used before the fusion of mid-palatal suture, and it avoids dental effect like extrusion of molars or buccal tipping of molars. In surgically assisted rapid palatal expansion, SARPE, method used after fusion of mid-palatal suture by surgical intervention. As with the help of osteotomies, surgical incision is done and palatal expansion is carried out after fusion of palatal suture. As we can see in the picture below, here we end our expansion in orthodontics. Thank you.